walking on a dream, the dream of integrated care. That's what we're searching for and in pursuit of. I think the organising committee is making me earn my money today and yesterday, and I promise you will hopefully not see me for the end of till the end of the program again. The journey on integrated care has been one of the seminal policy issues introduced by Minister Skinner in her first term of government. It was quite visionary at the time and really cognisant of the increasing burden of chronic disease to the health system, the multiple readmissions that patients were experiencing, and a real belief that there is a better model of care to manage people with chronic disease in conjunction with their GPs and, of course, the primary health networks. So to start off the session today, we have, I probably shouldn't say it, two of our leading PHN CEs, Walter Kmet and Vahid Sabiri. Welcome.
Thank you, Elizabeth, and congratulations. This is a wonderful festival and celebration, so it's really great for us to be a part of it. So Walter and I are both really excited to be invited to share our experience in regard to the patient-centered medical home, which is also known by many other names, healthcare home, primary healthcare home, and so forth. You won't be surprised that the reality is that the healthcare system is not patient-centered. Despite all the good intentions and a lot of efforts, our payment methodologies, incentives, system structures, and processes all result in a provider-centered care. So in a sense, you could say that the current system is perfectly designed to deliver what we're getting, which is not continuous, integrated, patient-centered care. And to get a different outcome, different care, the system has to be redesigned. Hence, the concept of patient-centered medical home. The idea here is that care is seen through the patient lens and not the provider lens. So what is it that we're talking about? I thought it would be useful, given that there are so many different versions of the patient-centered medical home, to maybe start by just looking at what it is that we're talking about. And I put up this concept schema, which is developed by Dr. Tony Lemke, to start a conversation in recognizing that there are many layers to the healthcare system. And so the first layer is the patient and family layer, where most of the care happens there. That's where most of the care that's received is in that space. Hence the concept that the minister and the secretary talked about earlier in regard to health literacy becomes so crucial, because patients who are empowered to be agents of their own care have better outcomes. So it's really crucial that that space is, we invest quite a bit in that space. The home, if you look at the first two layers, is what is the patient and family. The next two layers are what we call the medical home. And it is where the primary service provider, which in many cases is the general practitioner, and all the other services that are in that setting provide the continuous care that the patient requires. And then as you look at further how that changes, the concept here is that from the patient's point of view, each patient and their families can access the care that they need. The team is their care home. That's the first 4 layers, if you like. The team knows them well. They can access the care when they need it. And the team grows as the care need changes. So others come in to get, there are additional members that are added to the care team. From the clinician's point of view, this is a much better way of delivering services, where they know the patient well, they can track progress, and there is a trust trusting partnership that exists. Now, it's really also important to note that as you move down the layers, the care gets more intensive, more intrusive, and more expensive, and hopefully more intermittent as well. So you visit to the hospital is probably once a year, or maybe in 2 years or so. But your continuous care that you have, which is very patient-centered, determined by the patient goal, happens in the first 2 or 3 layers. It is comprehensive and joined up. It is much better for the patient experience and the clinician experience, and it's cheaper because the more upstream is less intrusive and less expensive. So this is a concept that when we refer to patient-centered medical home, this is what we're talking about. Now, what are the challenges in building such a concept or implementing such a concept? Firstly, it's a long game. It is a process and a journey. It's not something that you turn on a switch, you have it. It requires patience, persistence, and a vision, things that we're not really very good at. Secondly, it's about transforming the healthcare system. It's about continuous improvement based on a clear vision and approach. It's also what Elizabeth talked about earlier. It's about shift in culture, and that's really an important part of this, and it has to be bottom up. Additionally, it's about use of data to drive action and quality improvement. It's about having the right systems, a population-based approach to be able to deliver such a continuous team-based integrated care. In this construction process, patient literacy and empowerment is quite crucial. It is quite crucial how patients are viewed. They're viewed as collaborators, as partners in the care, as an important part, agents of their own health care, rather as passive recipients of health care that come occasionally, come periodically and receive prescriptions and go. It requires a change in the way clinicians view patients, not in a paternalistic manner, but as key collaborators. So what we're talking about here is a change management process, a change management that requires clinicians to be the bedrock of that change. So where do we start? So the important starting point for this journey is understanding how to engage clinicians in this change management process. And I'm going to use work done by Paul Plessick and some images from Dr. Tony Lemke's website. The concept here is that change agents often see themselves as if change just requires throwing a rock at the target. So if we have a target, which is the change or where we want to go, and it's like throwing a rock at it. So if we get the angle right with sufficient force and with trial and error, we can more or less every time hit the target. So it's all up to us. This is partly correct. In fact, a very small part correct. According to Paul Plessick, leading sustainable change is like throwing a bird at a target. The bird has a mind of its own and can fly. A rock cannot. So the important issue is not so much is releasing the bird, but having sufficient what he calls bird seeds or attractors so that the bird goes to. This is really a crucial issue in terms of our experience in engaging with clinicians. That is really important for them to understand why change is necessary and what that change looks like. So it starts with a conversation which results in a movement. So that second picture is having the right bird seeds or attractors as the place for the bird to go to. So the question for us when starting this process of building a medical home is, what is most important is the conversation about bird seeds. It starts with learning about how do we do this. It's about why the change is necessary, the burning platform, what does it look like? And this is not about cost curves and issues like that. It is about aligning our conversation to the values of the clinicians. And often the attractors for clinicians are things such as what is right for my patients, what makes my clinical life easier, what gives me mastery and recognition. And it's really important that those values are used as the basis of the conversation, because if we can win the mind and the heart of the clinicians, we can never get their discretionary effort that's required and the desire to be part of this movement for change. So that's the starting point. You cannot start a discussion with clinicians about cost curve. In fact, some of them find it quite abhorrent to have a discussion about costs in relation to the change that's required. But the conversation in itself is not sufficient. We need then the tools and the enablers, the processes and systems to make it happen. So quickly, what are we doing on the North Coast? We're starting with a movement for change. It is really important that this change process is a movement that people want to be a part of. Then we put together the Patient-Centered Medical Home Handbook and Toolkit, which is a continuum approach which outlines the continuum that a practice needs to move through to get closer towards that maturity that is required in terms of their practice. So let me just briefly mention to you what are some of parts of what is included in the handbook and the toolkit. We've used the US taxonomy methodology, maturation continuum. It's about what is PCMH and why. What is the journey to getting to the PCMH? What are the toolkits and enablers that are needed to get there? How do each practice does its own self-assessment, so it's not about competing and saying whether one is ahead or one is behind. It's about everyone is on a continuum, maturation or progress continuum, and deciding where they are and what their next steps are, and having the tools and resources to get there, and then case studies which are encouraging. But that is not in itself sufficient. So what we are also doing is building clusters of general practices, 3 or 4 clusters that are working with us as collaboratives, as part of a collaborative, to gain experience and to refine the handbook and the toolkit grounded in that experience. Then we are also working with universities to put together a graduate certificate in primary healthcare nursing, which is built on these enablers or building blocks. This is crucial because practice nurses are a key element of achieving this. But that's not in itself sufficient. There is a lot of other work that needs to happen around this work for us to achieve this patient-centered medical home. And that's a lot of work we're doing with the local health districts in our region in terms of shared care planning platforms, in terms of electronic admission and discharge flags. That graph tells you of the 200 of the patients that are currently in the chronic disease program, about 92% of them are using electronic admission and discharge flags. And then the integrated care program that the minister and the secretary talked about, which are really contributing to this. And finally, I just want to emphasize that constructing these patient-centered medical homes part of it is working with practices, but a large part of it is all of us working together to building the systems, things such as the health pathways, the health literacy program, the low acuity ambulance program, and the general practice collaboratives. All of these and many other things contribute to this process, and we need to work on all those fronts. And so the question is, are we making a difference? Only time will tell, but I think we're confident that with the right engagement of general practice as leaders and the allied health, primary healthcare professionals being part of this movement for change, and the right tools and resources and enablers, it is quite achievable. Thank you.
Thank you, Vahid. Some wonderful imagery, which I'm not sure I can compete with, but I'll do my best. In the short time this morning, I thought I'd cover 2 areas, and that is really what is it that we're trying to achieve in talking about patient-centered medical home, and then what are some of the foundations that we're laying. And in everything that we do here, there's just 2 areas that I think I should highlight. One is the role of a PHN, the role of our primary health network and primary health networks around New South Wales and the country is really centred around trying to build a capacity and capability for people in the system to work better. And that relies on integrating care, perhaps joining care up at some point, but also improving the capacity of each of those businesses, a lot of which are individual freestanding businesses, do their job better within the system. And secondly, the idea of partnership, the important partnership that we have here today in being able to be part of what is a whole health infrastructure rather than what is simply a primary healthcare infrastructure. And some of the work that's being done, especially around integrated care and the leadership shown by New South Wales in the recognition of the importance of those partnerships is critical as well. So when we talk about integrated care, we can frame our picture, as Vahid quite rightly said, around the patient and what is the patient's perspective. And I like this definition because for us to be able to do that, we need to be able to recognise that sometimes what we're doing is relying on what we've always done in the past. The supply-driven model that this quote relates to is around doing what we're doing now. How can we begin to change that? The fact that we're doing something now doesn't mean that it's right for the patient. We need to keep questioning that. And indeed, when we look at the perspective and the complex system we have, this is a diagram from the Integrated Health Program in Western Sydney. It's a complex system. It's a lot of people doing a lot of things. But what is our perspective? What is the patient's perspective, and how would we define that? Becomes a very important part of not only what we might term a patient-centred medical home, but an integrated healthcare system. And when we integrate care, there are two important components. Certainly, and most definitely, we want to connect that system up better. We want to be better at doing things together. We want to be able to ensure that journey is smoother, is more seamless, as the definition said. But also, we need to have an eye on what it is we want to do in the future and how that system needs to transform. So the integrated care journey is partly around the connecting, but it's also significantly around how do we transform what we're doing to something different in the future. And I think that change management and that investment in that journey is something Vahid, I think, talked about quite importantly, that integrated care has those two components. From a patient-centred medical home perspective, what would we say the principles? What are the principles that matter? Well, you can take your time to have a look at some of those principles. And when we look at our work in patient-centred medical home, it's about trying to reinforce each of these 5 principles. And these are pretty much universally accepted. They've now been adopted by the Royal Australian College of General Practice in their definitions. So we're starting to have emerging principles that are very consistent with where it is we want to go. And indeed, some of those are not inconsistent with where good quality healthcare and certainly good quality primary care has been in the past. And some of that transformation begins to look like this. Following Twitter yesterday, I noticed the Secretary was talking about volume to value. It's one of the items on this slide. But it's about saying, this is what today looks like. How do we move to a future state? And when we look at some of that future state, it's hard to argue that that's really where we want to go. But it means we do need to transform what we're doing more than just connecting better what we're doing. And certainly from a primary care perspective, another perspective, I guess, on Vahid's initial presentation, and that is that we're putting the patient at the centre of their care. The idea of referral, continuous referral around the system, is part of the problem we've got. The fact that we move people from one part of the system to another. And primary care has got that problem just like many other parts of the system. How do we reduce referral and improve continuity of care? And that's something that certainly, as we talk about what it is we're trying to achieve, is very important to us. So laying the foundations. Well, those foundations are sometimes pretty messy. It's a cobbled road in a sense. A lot of what we're doing and a lot of what we need to do already exists. We just need to try to put that back together. A lot of the cobbles on the road have already been well worn. Some of those need to be reused and put together in a better way. So that journey around patient-centred medical home and better integrated care is a journey, but it's a journey a lot of the time in trying to bring things together that perhaps haven't been fitting together so well in the past. But it's using the resources we have, because there's no such thing as a new program which is going to solve all our problems or all our desires. In Western Sydney, when we went along the integrated care journey, we were very conscious about this definition, the definition of what we might call integrated care, and we came up with this definition some time ago, some 3 years ago, I think, 3 or 4 years ago. And we're very conscious of trying to implement that part of that integrated care picture, a picture that includes, we define as a quadruple aim, the triple aim plus one, and then looking at how we can better understand needs, target our delivery to those needs, and ensure the enablers are there to support what we're trying to do at a service delivery level. And that's a framework that has been a tremendous partnership between ourselves and the local health district and the Sydney Children's Hospital Network and other providers, including general practice. And understanding what that looks like and where we fit into that picture has been a very important part of our role. From a primary care perspective, we've put a lot of store in what we call the building blocks. And the building blocks are evidence-based definitions of what is defined as good quality and high-performing primary care. And when we do our work, what we say is, how do we improve each of those, any one or each of those building blocks? If we do something, how does it lead to better team-based care, for example? And looking at this framework has been an important part of our journey, and as Vahid said, bringing together a common view of what it is we're trying to achieve, and certainly in general practice and primary care, this has been an important part of our journey. In terms of that, in terms of the initial bit, and Vahid stressed this very strongly, and I won't keep stressing this, the idea of leadership and change management is critical. And as the first building block talks about, the idea of shared leadership is something we have to invest in. So even in talking about years of a journey, we're still continually investing with general practitioners, with primary care providers, and together with acute care providers in what does change management look like and how do we support that change. Understanding that general practitioners and primary care providers are a dispersed system, and change management and leadership isn't the first thing that comes to mind for them when they turn up for work in the morning. And indeed, they don't often have the time even to think about it. So how do we, as a system, provide that support so that can happen? Part of the journey, of course, is saying, where will the money come from? I mean, as Danny O'Connor will say to you, we're often advocating as to how we can make this happen. Because there isn't going to be new money that's suddenly going to appear in the system. We have to find ways to move money from where it is now to other parts of the system. But you can't do that without a strong partnership, which is why I emphasise that again. The idea that we might have co-creation of healthcare is that partnership, and that is fundamental in being able to shift, I guess, our view of the world and keep people out of hospital, which is really something that I think we all want to do if we possibly can. And in terms of those cobblestones being put together and some of the ingredients in the system that we've looked at, this is just a bit of a diagram of the things that we've worked on, and each of these reinforce some of those building blocks, let alone the integrated care picture. We look at what system enablers there are there, what we can do there, and you've seen health pathways there, as Vahid mentioned, very important part of a very important ingredient for us. Those system enablers are ones that we're very keen to invest in. The integrated care investments, which have come with that co-investment with the New South Wales Government and the Ministry and Western Sydney Local Health District, very important. Things like the case conferencing in diabetes has been a very important building block. And the building of general practice capacity, certainly a fundamental role as far as us as a primary healthcare network is, but also an important ingredient in this integrated care and patient-centred medical home journey for general practice and primary care. So, one last slide, and this is really a reflection on change again. It's been a pretty big theme from both of us around change management. Change isn't easy, often incremental, and often not the way we often expect it. And I think this paper by BOMA very recently outlines the complexity and the challenge of change, but somehow and also reinforces the fact that it's going to take a bit of time. Thank you.
Thanks, Walter. Have a seat. So take us to the practice that you're most proud of in your relative areas, to just put flesh on the bones of what it looks like when it's working. Do you have any practice in either of your PHNs that you think is the way a patient-centred healthcare home or medical home should look like? Vahid, Byron, you know, Byron Bay, Ballina, you know, sort of Lismore. Where we got? Actually, no, just do it from there. Actually,
Do from there?
yeah, do
Okay.
it from there. Yeah, just kind of keep you under control.
A practice that I would probably single out to say we need to look at patient-centered medical home as a continuum, not as a destination that they have arrived and they're there. It is a process.
That's a great way to avoid evaluation.
No,
Vahid.
I'm not avoiding it. I'm not avoiding it. This is déjà vu in some ways, isn't
No,
it?
but go on.
It has to be that. The building blocks that Walter talked and I talked about.
Okay, that's the throat clearing. Take me to a practice where you think it's working pretty
A practice that's working well is where they have a multidisciplinary team that works, that have rights in the hospital that for the patients, their patients, that they actually are part of the team in the hospital. And there's one in Alstonville that does all of that.
So they admit
that they
direct to the
actually
ward.
they have beds in their clinic for patients who need IV antibiotics and other things. They actually do day procedures. They working with the hospital. So there's a lot of interaction between the specialists. There's a lot of interactions with the hospital, especially for the patients who go to the hospital. They provide a comprehensive set of services, which includes a range of allied health services within the practice. So, and they have very good after-hours care. They do very good in-hours care, which reduces the need for after-hours, but they have very good after-hours processes.
And just a question, to what extent, New South Wales has not been very good at picking up the rural generalist pathway for training, you know, depth in rural and doctors, GPs working in rural and regional areas. To what extent, if we were to adopt that model in New South Wales, would we get improved integrated care, or would we just be creating new specialists?
I personally, I don't feel there is any option but to adopt that model. I don't think it's going to be creating a new subspecialist set of practices.
So you think it's essential for success?
Absolutely, it's essential because the patients are receiving really good care. The clinicians, they know clearly what their role. A clinician wants to know what exactly their role is in the care program, when in the care team. So all of these are important parts of clinical satisfaction, good patient outcome. This practice also has a advisory group that advises the clinic on its work, which includes patients. So it's multi-layered.
So Walter, take us, you don't have to name any names, but take us to the practice that you think is closest to your vision.
I think some of the points Vahid made around team-based care I think are critical in answering that question. But if I could say one thing about a practice that is at the top of its game, it's a practice that manages its population of clients, its population of patients, not just because they're in front of them. So the idea
so
that
they know they've got 464 people with type 2 diabetes and they know where they live.
That's right.
So that's the practice manager rather than the GP.
Well, yes and no, because the GP needs to take a role in saying my role is more than just seeing 30 patients or 20 patients a day in front of me. It's a role around managing my team, it's around knowing my population, it's around creating that leadership that we're going to approach the way in which we do business proactively rather than just allowing business to come in. And I think that's the most basic form in the sense of preventative care, because if you know your population and you know who you're dealing with, you can be proactive around things that may happen.
So let's talk,
they're the good practices.
So let's talk finally about birdseed. What's the incentive for GPs to buy into this?
Well, I think the first...
You're going to tell me good care,
yeah,
and they'll tell you to piss off.
I think the question, Norman, is how you enable good care, and I think Boehmer's paper, which I presented, the last point in the slide was it's not just about the money. Clearly, an enabler, as it is in integrated care diagram, it does hinge partly on the money. But we are working with those early adopters and those GPs who actually are getting much better satisfaction in providing better patient care, and that being something we can enable. So I think we're not going to change the whole system. What we're trying to do is work with those early adopters to do something differently.
Very final question to Vahid, another career-ending question. Everybody in this room is devoted to better healthcare within the framework of New South Wales Health and recognise they're working within a system where the federal government also has a role. You march to the tune of the federal government. They're the people who fund you. They set your agenda. It's not necessarily pernicious, but it's often a different agenda. How do you meld the two?
Well, there are often challenges. One example is the current, the Commonwealth, if this is career-ending, Commonwealth primary healthcare pilot that's being implemented, which is called Healthcare Home. But in essence, it's really just trialing a bundled payment methodology, where we've been discussing with Commonwealth and saying, if you really put that out as to be the whole healthcare home model, and stop us from doing everything else that we're doing, because that's kind of part of the discussion, it is quite damaging. So how do you make sure they fund us, they draw the, if you like, the boundaries and what we do? How do you manage that is a challenge that the sector has, and primary healthcare, the healthcare home model pilot is a very good example of that. And it is a challenge that Walter and I now face
So you need help at a COAG and a jurisdictional level to convince the federal government to integrate that into a broader integrated care story.
And if I may add, I think New South Wales has been the exemplar, and the New South Wales Integrated Care Program, the Minister's intervention with the primary health networks in terms of even the numbers in New South Wales, and the current commitment. The fact that we're sitting here and talking to New South Wales Health about patient-centered medical home, it just shows the commitment of New South Wales Health and yes, we absolutely need that support, and we're grateful that we have it.
Yeah, just to go to Victoria and see the dog's breakfast they've got there. Thank you very much indeed.
Thank you.